Hello, future PTAs. All right, we're talking about electrical current for muscular contractions. Can't get it to go to the next slide. All right, here is our outline. And neuromuscular electrical stimulation is one of the types of electrical stimulation that causes a muscle contraction. It can cause a innervated muscle to contract, so that is the type that the neuron is still attached to the muscle, and so you can still create an impulse from your brain that reaches to your muscle, so there is a possibility of that muscle being strengthened on its own eventually. That's kind of the goal. So during physiological muscle contractions, small nerve and muscle fibers, or type 1 slow twitch fibers, are recruited first. During electrically stimulated muscle contractions, larger nerve and muscle fibers, or type 2 fast twitch, are activated first. So I've explained it before as when we create our own muscle contraction, the smallest muscle fibers contract first, and as the intensity grows, then it branches out to the larger and larger muscle fibers until the full muscle contracts. With the electrical stimulation, the largest diameter fibers, muscle fibers, contract first, and then it goes down to smaller and smaller nerve fibers and muscle fibers, really, to create that contraction. So when you're doing neuromuscular ESTIM in a perfect world, the machine contracts and the person voluntarily contracts their muscle at the same time, so that it's getting the largest diameter fibers all the way down to the small, and then your own body is doing the small to the large. So it's like a full muscle contraction. Hopefully that makes sense to you. Longer recovery periods are needed when you're using type 2 muscle fibers than type 1. And it's ideal to do both contractions together. So if you remember learning about aerobic and anaerobic metabolism and slow twitch versus fast twitch muscle fibers and all those things, that can help you understand some of this. So the type 1 muscle fibers are slow twitch. They're not quite as strong as type 2, but they're more resistant to fatigue and atrophy. Those are your muscle fibers that are most active in the oxidative or the aerobic metabolism. They use oxygen. The type 2 are the fast twitch, and they're stronger, but they fatigue more easily, and they're more active in that anaerobic metabolism. So when we stimulate our own muscle contraction, the first ones to stimulate are the slow twitch, and then they get to more and more strength into the fast twitch. With the machine, the fast twitch and the largest diameter fibers are first, and then it kind of trickles down. The order, all right, we talked about that. Okay, the chart at the bottom is how quickly muscle fibers fatigue with varied rest times. So it's important, especially when you're doing ESTIM, to create a muscle contraction, to allow increased rest times, because you're doing so much activation of those type 2 fast twitch fibers. They require more rest time, because if you remember, they basically deplete the oxygen, and then they don't really kick in again until there's some oxygen restored to that area. And so you have to, so it's like fast bursts, like if somebody sprints a very short distance and then they stand and they recover and they breathe, and then they go and they sprint again a very short distance. It's like that. So you want those recovery times when you're using neuromuscular ESTIM to allow the muscle to have a good contraction every time and not fatigue. And so when they did a contraction for a second and off for a second and alternated, the muscle fatigued within 2 minutes, versus when they did alternating between 1 second on, 2 seconds off, it fatigued significantly within the first 2 minutes, but still kept declining pretty quickly within 8. Versus if you put an on time of 1 second and an off time of 5 seconds, then the muscle fatigue was the least. That's that purple line at the top of that. chart. So this has indicated like a 1-to-5 ratio is ideal, 1-to-3 or 1-to-5 on and off times, that the contraction lasts for about a second and then you rest for 3 to 5 seconds in order to avoid over-fatiguing and not getting a good muscle contraction. Physiological muscle contractions are asynchronous, so they gradually turn on, so it's more of a graded muscle contraction, whereas electrically stimulated muscle contractions are synchronous, so they turn on all of a sudden, all at once. So sometimes it will cause kind of like a jerky, sudden muscle contraction that's not as similar to your normal muscle contraction. A different type is EMS, which is electrical muscle stimulation, and this is in a denervated muscle. So here, this first figure shows a neuron that's touching a muscle and it's communicating with the muscle. When something happens and changes that, either because the axon is damaged or they have some type of like demyelinating disease or something that's damaging the neurons and losing the signal, then no signal is getting passed to the muscle, and so the ESTIM can kind of override that and still cause a muscle contraction even though the nerve is not intact. So it directly stimulates the muscle to depolarize with a current pulse duration of at least 10 milliseconds. Okay, so at least 10 milliseconds of the pulse duration in order to cause a muscle contraction there. When the muscle contraction is physiological, you have told your body to do it. The slow twitch or type 1 muscle fibers contract first. There is a low contraction force, a slow speed of contraction. It's fatigue resistance. You can continue to contract it over and over, and it's atrophy resistant, so it does not, the size of that muscle doesn't decline as quickly with decreased use or with immobility or healing or anything of that muscle as the other type 2, and it's asynchronous, as I noted before. When the muscle contraction is electrically stimulated, the fast twitch or the type 2 fibers contract first. They have a high contraction force, or really strength is kind of what that's talking about. A fast speed of contraction, they fatigue quickly, they atrophy quickly. So even after a surgery, if you're not using that muscle, then you will lose more type 2 muscle fibers more quickly than type 1. It's synchronous recruitment, which we just talked about. We've talked about a lot of the stuff that I have in the notes there. Here in this picture, the slow twitch is the type 1, and they are aerobic. They require oxygen, so there's more red blood cells in those type of muscle fibers than in the fast twitch that are anaerobic and do not use oxygen for the production of energy. Remember, we were talking about like ATP and glucose molecules being used for energy in these type of metabolism. So, and see what else I need to say here. I think I've covered all of it. Yep, so you need more rest time when you are doing an electrically stimulated muscle contraction than your physiological muscle contraction. The overload principle, anytime you're trying to strengthen a muscle, the overload principle is key. So you need to place greater force on that muscle and to produce a greater contraction in order to gain strength. So if you're doing the same thing every day at the gym and you never change it and you never increase the reps or the weight or the sets or decrease the rest time or anything like that, then you're going to just keep the same muscle strength and it's not going to improve. So you need to either increase the duration, the amplitude, the electrode size, or something like that in order to recruit more fibers when you're doing strengthening through electrical stimulation. So just like with other types of strengthening, you have to overload the muscle in order to produce greater strengthening. Specificity, just like with working out, only the fibers you contract are strengthened. So if you're doing bicep curls all day, don't expect the quads to get bigger. Electrical stimulation has more of an effect on type 2 muscle fibers than type 1. That should be obvious since the type 2 fibers are stimulated first and most with the electrical stimulation than with your physiological. Disuse atrophy is primarily in the type 2 fibers, and so it's really key when you're trying to avoid disuse or atrophy, when you're trying to avoid losing that muscle tone, to do some type of electrical stimulation is a good way to do that. I love this picture because you see so many people at the gym working out their upper half and forgetting about their legs. And if you don't work them out, they're not getting any bigger. All right, here's our roadmap of the types of applications for neuromuscular or electrical stimulation of a muscle to create a muscle contraction. You can use it for orthopedic conditions, cardiorespiratory, for athletes to avoid deconditioning, to improve coordination, to decrease swelling, and to slow down atrophy of a denervated muscle. Okay, so we're going to go through each of those. So for muscle strengthening for orthopedic conditions, it could increase strength after a surgery like an ACL repair or a total knee arthroplasty, a knee replacement. For non-surgical management of knee conditions, so you could also use it to strengthen the quads and help support the knee more and decrease that muscle imbalance that may be putting pressure on certain parts of the knee, and strengthen to avoid a surgery as well. With cardiorespiratory and functional training for patients with cardiac, pulmonary, and critical illness, neuromuscular or electrical stimulation, whichever type you're using, has the potential to improve peak oxygen uptake, 6-minute walk test distance. The reason that's important is gait speed has kind of been considered the most important vital sign, the 5th vital sign it is often called, because gait speed often indicates life expectancy more so than blood pressure or heart rate or respiratory rate. It is an indicator of if somebody is likely to fall or not, and kind of their total health. So it's important to improve gait speed in order to improve function and quality of life. Other things that can affect is, of course, muscle strength, flow-mediated dilation, depressive symptoms, and quality of life. Athletic performance, so you could add neuromuscular ESTIM to athletic training to enhance strength gains, but it may or may not actually affect the performance, so it's not always a guarantee. And it's not a substitute for sport-specific training. So you can't just expect the ab machine to sit there and work your abs out for you, and then you suddenly have a lot more core control if you're not doing actual movements and things that you need for whatever sport you're playing with the stimulation. Contractions have to be at least 50% of the maximum voluntary isometric contraction force in order to increase strength. So the MVIC is maximum voluntary isometric contraction, and each contraction needs to be over 50% of that maximum contraction force in order to increase strength. ESTIM can also be used to counteract deconditioning in older adults, especially if it's an adult that is not exercising regularly, maybe because they don't have access to areas to exercise, they have just restricted mobility, they have been sick, anything like that, then it can counteract the muscle loss or the loss of muscle mass and strength that naturally occurs with age. Working out could counteract it even better. So this is not to replace working out, but in a situation where they can't, it could help decrease the speed at which they lose that muscle mass and strength. It can counteract that atrophy, increase their strength, increase mobility, and increase function. But remember, working out is better. So if they had a choice, work out or put this machine on, working out is better. But if you could do both, it would be helpful. So improved muscle coordination and motor control for neurological conditions. So functional ESTIM integrates the NMES with the functional activity. So you put the electrodes on and then you have them walk. So the electrodes are stimulating the muscles needed during specific parts of the gait cycle to help their functional mobility. Even sometimes people with like a spinal cord injury could have a certain machine that they hook up to that allows them to walk after the spinal cord injury, even though they don't have any nerves that are speaking to their muscles. If that machine is contracting them at the right time in the right sequence, it could help them walk after a spinal cord injury. So patients that may benefit from it are spinal cord injury, stroke, those with multiple sclerosis, traumatic brain injury, cerebral palsy, any type of ailment with the CNS. They could possibly benefit from functional ESTIM to allow them to do things that their body isn't naturally doing. All right, with stroke, so we're going to go into each of those. You could stimulate the lower extremity and it could improve gait, the ankle dorsiflexion torque, the agonist, antagonist, contractions. So sometimes with spasticity after a brain injury or with cerebral palsy or things like that, there are contractions where rather than one muscle relaxing while the other contracts, both are fighting to contract at the same time and one is not relaxing. So it could help break that cycle and decrease the co-contraction so you're getting a better contraction without fighting against your own muscles. It could increase the probability of returning home and to your baseline, your prior level of function. There is a thing called an EMG-triggered NMES, neuromuscular ESTIM, which there is EMG electrodes on the patient's muscles, and when the patient contracts the muscle themselves, the EMG picks up that signal and stimulates the neuromuscular ESTIM to cause a contraction. So the patient first activates their own muscle, the machine picks up that contraction and sends out impulses that increase the contraction. So you're kind of leading it, but it's helping you along the way. There is an antagonist contraction reduces agonist spasticity. Okay, so you could stimulate the triceps to reduce spasticity in the biceps. So typically, how our brain should work is that when one muscle is contracting, an inhibitory signal is being sent to the antagonist muscle. So if our bicep is contracting, then the tricep should be getting a signal that says relax. So if I have tone in my biceps and I want to send a relax or an inhibitory signal to the biceps, I could put ESTIM on my triceps and create a muscle contraction, and as it's contracting, an inhibitory signal should ideally get sent to the biceps to inhibit the muscle contraction and decrease spasticity. If you just want to increase strength and control of a muscle, you want to put it on the agonist. Okay, so if you're wanting to strengthen the biceps, put it on the biceps. But if you're wanting to relax the biceps, you could put it on the opposite muscle and contract the triceps in order to try to force that biceps to relax. For a spinal cord injury, electrical stim could be used to counteract disuse muscle atrophy to improve circulation. Some of the things it's been used for in the past is for walking, like I just said, for hand gripping, for breathing, for different conditioning, for bowel and bladder voiding. However, in order to use ESTIM for someone with a spinal cord injury, there has to be enough force to carry out the activity, so the muscle can't be so atrophied. So typically right after the spinal cord injury happens is when you would want to start this and not wait until the muscle's atrophied enough that it doesn't generate much force. It does not need to be painful to the patient. If it's painful, then that's not the ideal treatment for them. It needs to be in a situation that can be controlled and repeated. If you're only doing it once in a while, it's not going to do much. And it's only going to maintain that muscle while you're still doing it. So like if you do it for 6 months after a spinal cord injury and then you discontinue it, well, then their muscle is going to start atrophying after that time. So it's only going to help as long as you're continuing to use that electrical stimulation frequently. And then as long as the person with the spinal cord injury agrees to it. Of course, every treatment that we use, we want them to agree to before we just put a treatment on somebody. For edema control and improved circulation, so contractions of the limb, those muscle pumps push the fluid back to the heart. Remember, most of our venous return is from muscle pumps because we don't have blood pressure pushing it back through. Our blood pressure is pushing our oxygenated blood out to the tissues, but once it reaches the tissues and gets into the venous system, the veins are not pumping it back. They just have the valves that are keeping it from backflowing, and our muscle pumps are what pumping it back to the heart. So stimulating that muscle pump can help the fluid in the veins and in the lymphatic vessels to be pushed back towards the heart and out of the limbs. It can reduce edema caused by poor circulation due to lack of motion, but it should not be used if the edema is either caused by inflammation. So if there's acute inflammation and there's swelling in that area that's good for the healing process, you don't really want to remove that fully. And then, or if there's organ failure. So for an example, if you're in congestive heart failure and your heart is already not pumping sufficiently enough to withstand the load it's being given. So the heart is already overloaded and can't keep up with the amount of blood that it's circulating, and so the blood is backing up into the lungs. If you then send more blood back to the heart and it's already overworked and not able to keep up, you're going to make the symptoms worse because it can't keep up, and now we're making it work harder. So you don't want to, if there's organ failure, even like kidney failure or definitely heart failure, anything like that, you don't want to push the fluid back towards the heart or out of the body. The kidneys filter it before it goes out of the body because you're then requiring more of an already overloaded system. So the other thing electrical stim can do is to slow down atrophy and improve function of a denervated muscle. We've kind of said this several different ways, but if the nerve is not attached to the muscle, then we cannot physiologically, by our own strength, cause a muscle contraction no matter how hard we try. But with this ESTIM, it can continue to contract the muscle and keep it from losing as much strength and atrophy or becoming fibrotic. So the muscle tissue being replaced with scar tissue or with fascia or other types of tissue, fat, sometimes it will be replaced with. However, if the nerve does not regenerate and it never fully attaches back to the muscle, so it doesn't heal in a way that we can eventually produce a physiological muscle contraction, then the outcomes won't persist once you stop the stimulation. So once you stop using ESTIM on a regular basis, you'll eventually have atrophy anyway if the nerve never regenerates or never heals. All right, our contraindications and our precautions are the exact same ones that I have just went over in the intro to ESTIM lecture, but I'll go over them again really quickly with the contraindications. You do not use ESTIM if someone has a pacemaker, a defibrillator, unstable arrhythmias. You don't put it over the carotid sinus and the carotid arteries. You do not use it over an area with a blood clot or over the trunk of a person who's pregnant. And then precautions, any heart disease, impaired sensation or mentation, cancer, and skin irritation or open wounds. These are our contraindications and precautions. Adverse effects, burns, skin irritation, and pain are the main things, so you want them to tell you if they're having any pain, so you stop it before it becomes a burn. Application, just like many of our other modalities, you evaluate, you assess if it's safe, then you select the device, you prepare the patient by explaining the procedure, removing metal and clothing, inspecting the skin, putting them in a good position. Then you check and apply the electrodes. You select the treatment parameters. Some of the parameters you need to select are the waveform, the frequency, the pulse duration, on and off time, ramp up and down time, and treatment duration. So you got a lot of parameters to set on this machine. Then you turn the machine on. You turn up amplitude to the desired strength of the muscle contraction. So rather than with IFC, when you say, tell me when you feel it, now tell me when it's strong but not uncomfortable, and the patient decides when, you kind of turn it up. You say, tell me if it's too uncomfortable, and you're watching for a muscle contraction. And once you see it, then you either stop, or if you're like, it's barely contracting, I want a little bigger, you can turn it up a little more as long as it's comfortable for the patient. It can get really uncomfortable. Then you assess the outcome and you document what you saw. For the placement of the electrodes, one electrode needs to be placed over the motor point of the muscle. So we saw that in some of the beginning slides of putting it in the place where it's most active, where it causes the best muscle contraction. And then the other, you place it in alignment with the way that the muscle fibers are aligned. And so if the muscle is running up and down and you have one electrode here, then you put another electrode at least 2 inches away, parallel to the way that the muscle is already aligned. The fibers are already aligned. So with the VMO, as you see, if they place one electrode here, the muscle fibers are aligned in a slanted in a diagonal pattern, and so you place the other electrode at least 2 inches away and a little bit diagonal to that first electrode in the same direction that the muscle fibers would naturally run. You want the person's their joint to be in mid-range, and then you can decide whether they're doing an isometric or an isotonic contraction. Not whether. They are. They're typically doing an isometric. Occasionally, you'll have them, move the limb or something, but usually you're doing an isometric contraction. For our pulse duration, the amplitude is typically, contracting greater than 10% to 50% of that maximum volume isometric contraction of the uninjured limb. So you figure out what type of maximum contraction the uninjured limb is, and then you do 10 to 50% of that. Remember, at least 50 is ideal for strengthening, but since that limb is weaker, it might have just a little bit different, so under 50 might still strengthen that limb. The pulse duration is 150 to 350 microseconds. The frequency is typically 20 to 30 pulses per second for a small muscle, 30 to 50 pulses per second for a larger muscle, and if you use more than 50 or up to 80 pulses per second, it could increase strength, but it's also likely to increase fatigue. So you want to be careful about turning it up too high, and you want to make sure they have enough rest time in between so they have good contractions continuously. The on-off time, typically it's on between 6 and 10 seconds, and then off 50 to 120 seconds, depending on how many seconds you had the on time. So the off time needs to be at least 3 to 5 times the on time. So for every second that it's on, they need at least 3 to 5 off seconds. So if it was on for 10 seconds, they need at least 30 to 50 seconds off. But obviously in the book, it's recommending even more than that by saying the off time needs to be between 50 to 120 seconds. And then there's the ratios again. The ramp up and down time is typically 1 to 4 seconds, but if they have a spastic antagonist muscle, so that example earlier, if the biceps is tight and you're using it on the triceps, you want a longer ramp up time because you're wanting to try and start stimulating that and send that inhibitory signal. That's the important part of why we're doing that while it's ramping up. So more than anything, we're trying to send that inhibitory signal. All right, for documentation, it's very similar to our other modalities. We document what area we treated. We document our patient's position, the parameters, where we placed the electrode, how long we did the treatment, and the patient's response to the intervention. So if you have any questions, let me know. Otherwise, I'll see you in the next lecture.